Thank you for joining us today's webinar. I'm going to introduce today's speaker, Dr. Pedro Santos. He's the head of Laser Study Group of the Portuguese Aesthetic Medicine Society. And now, Dr. Pedro will share his insight and ideas about new protocol with the ULTRAFORMER III treatment, UltraFoxI. Please welcome him.
Thank you, Gina, for your kind introduction. And I would like to thank Classes for the kind invitation. And I would love to lead you on the next minutes talking about the procedure that is, for me, an everyday procedure with a very nice feedback from our patients. That is the UltraFoxI on a science-based approach, giving us predictable results. Let me start for stating that when one trusts the technology, basically one gets advantage of that of it. And our lunch hours could be doing some touch-ups, and if we didn't believe our technology, this is actually myself, we wouldn't use on ourselves the technology that we use on our patients. So let me review a little bit some concepts that I think that have to be cleared before we move on. We all know that UltraFormer is an ultrasound-based technology that uses ultrasound on a micro and macro-focused way. And it generates micro 3D spheres of thermal damage. On the literature, we find usually the designation of TCP, thermal coagulation point. But we have to have in mind that we are not generating points, we are generating spheres, we are generating a three-dimensional lesion. So when we think about that, we have to think about two kinds of effects. The first effect is the immediate one. As we are reaching temperatures higher than 65 degrees on a very short period of time, basically what we are inducing is protein coagulation. And obviously, with this coagulation, we have shrinkage of the fibers. And on the other hand, by the diffuse thermal stimulation mediated by heat shock proteins, we already know that the heat is a very nice stimuli to our tissues, and that leads to neocogenesis. And this effect is what is responsible, which is responsible for the long-term and progressive effect that we see with our treatments. So let us play a little bit and think about a machine washer for our clothes. If we get a t-shirt and get inside of the machine at 95 degrees, we all know what's going to happen. Basically, the t-shirt will shrink, and this happens because the fibers of the t-shirt are the tissue of the t-shirt. Sorry, is made of fibers as our skin. Basically, on the machine washer, we are coagulating, let us say, the fibers and lead to the shrinkage effect that I've told you about a few seconds ago. And this is just to remind you that we have these three-dimensional lesion zones that we are inducing, and on the inner part of the sphere, the inner core, we have the coagulative zone, and the outer core, we have the diffuse thermal stimulation of the surrounding tissue. And I would love to clarify with you the importance and the clinical significance of the two of the parameters that we use. Obviously, there is another parameter that is truthfully bordered and reached, that is the cartridge shoes, meaning that the depth of the effect that we are seeking. But the other two, we have to have in mind what A change on these parameters will change the response on our tissues. And basically, when we set up the energy, we set up the size of this damaged sphere. So when we increase the energy, the size of the sphere increases. So we increase the intensity and the magnitude of the effect. When we talk about pitch, the pitch basically is the distance between the center of each one of these thermal 3D spheres damage. And when we lower the pitch, as you can see here, here we have a higher pitch and a lower pitch. When we get the pitch lower, we can increase the thermal intensity of the interaction and also the density of tissue treated. Starting to speak about font size. If we check on Google Trends, we see that we have a tendency, and we have on the last 4 years, 3 years, sorry, we have a growth of the interest of this procedure, and not specifying the way, the method used to achieve or to use to treat on this indication. And if we Google it, we have more than 793 million results in just 0.5 seconds. So this is a major indication with growing interest and seek of this procedure from the patients. And why do we need to talk about font size, and why is raising interest from the patients? Because we know that the lateral brow elevation is a hallmark of two important things: youthfulness and attractiveness. And if you see this couple of images of two of the more consensual, beautiful women on the world, you see that they have the lateral brow more elevated and angled outwards to have this open eye effect, and that give us the feel when we look at pictures of youthfulness and attractiveness. And if we talk about attractiveness and youthfulness, we have to understand why do we lose this youthful appearance. And on the periocular zone, we have a multistructural aging, and we have to acknowledge the aging of each structure to set up a proper treatment plan. So we start from the deep structures as the bone. We know that with aging, the orbital rim gets, and the orbital cavity gets larger. Basically, the diameters is increasing with age, and with this, we start to lack support of the soft tissues, and the brow basically starts to run lower the orbital rim, and this affects leads to optical effect of the descent and the shadow of the below the eyebrow. On the other hand, we know that on the soft tissues, we have loss of elasticity and start of the sagging. And all of these effects together lead us to periocular aging, and the feeling when we see a picture of a periocular aged situation, of this lack of youthfulness and attractiveness that we have to seek with our treatments. And we already know that in our armamentarium, we have several tools to address this issue. Let's start with the pretty old, let us say, botulinum toxin. And we know that when we address this issue with the toxin, we are only dealing with the muscular component. So we are somehow forgetting to treat the elasticity of the skin and the skin sagging. We also know that we can treat, and not talking about the need for touch-ups every 3 to 4 months to get the results somehow constant along the time and stable along the time. For the other hand, we know that we can optically disguise this brow descent, placing filler as hyaluronic acid below the brow to have light incidence change and somehow giving the appearance of a youthful look, but it's a masking effect rather than treating the cause and the etiology. After that, we have the thread lifting that I will discuss next on. And also we have the surgeries, for instance, the endoscopic brow lift or the mini lateral brow lift that already that also have the indications, but we know that the degree of invasiveness is uncomparable with the other options. And as the bottom line, as topic of today, we have the microfocus ultrasound as an alternative to deal with this issue. I would love to spend some minutes discussing the trends of the threads, and I would love to aware you that indeed the complication rates are rising, and we are seeing every day more infections, superficialization of the threads, skin irregularities, granulomas, and for me, one of the most important side effects and complication is the fibrogenicity of the PDO molecule that will lead to scar collagen formation. And if we start to perform this procedure every year on a 30-year patient, if the patient at the 45 wants to perform a surgical approach to this area, probably I wouldn't like to be in the position of the plastic surgeon to do that because of the scar tissue that was generated of multiple thread application. And besides these complications, we have the side effects from the placement, the bruising, the swelling, the cutaneous irregularities, even if temporary. So all of these combined with short-term effects of this procedure give us, basically I would somehow provoke you, asking you if are we still on the lift, mainly with this kind of thread lifting. And for me, the answer is pretty straight. It's a no. But if we got a 20-minute procedure that is totally non-invasive with no downtime, with a very low risk of complications, and if these complications are associated with bad training or insufficient technique, and if we are inducing more than a cicatricial response, a regenerative response from the tissue, this would be almost the genie coming out of the Aladdin's lamp, because this could be a very nice solution to our problem. And this leads us to the ULTRAFOX eye. First of all, before starting with the protocol itself, I would love to remind you the forehead anatomy. We have several layers, starting from the skin, after that the subcutaneous layer, the aponeurosis, the muscle, some fat or loose connective tissue, the periosteum, and the bone itself. And we have to have this in mind because we have to know what structures we want to treat and what structures we don't. Basically, on this area, we will want to treat the muscle, the fascia, or aponeurosis, and the skin, and thinking about the Mendelssohn ligament area and tree, and we have to have in mind the first branches of the tree starts on the aponeurosis. So if we lift the aponeurosis, we bring the skin upwards, joined with the aponeurosis. But the anatomy also has a role for avoiding complications. And on this particular treatment, our main point of concern are the nerve anatomy, the supratrochlear, the supraorbital, having in mind the lateral branches of the supraorbital nerve, and the deep one too, and on this side, the zygomaticotemporal nerve too. So on a resume, the supratrochlear, but it's not so important because we are treating laterally. The supratrochlear, mainly the lateral and deep branch, and last but not least, the zygomaticotemporal nerve that has a pretty variable anatomy, and we have to have in mind this variability, mainly to paying attention while performing the treatment for any symptom of nerve heating of the microfocus ultrasound. Another thing that I would like to bring you, this is from a patient of mine, but I can tell you that this is quite reproducible. And if we check the ultrasound anatomy, we see that the periosteum is more than 4 millimeters deep. The frontalis muscle, about 2.45, and the fascia, about 2 millimeters. And I think that the fascia being at 2 millimeters depth starts to ring all of our bells to our MF2 cartridge. No, so basically we are already seeing that for treating the fascia, one of our major options on the forehead is to use the MF2. And our starting point for this protocol is this paper from these colleagues that started to treat the forehead with 3 millimeter cartridge, and they got the conclusion that the MFU is effective for brow lifting, and they achieved, beside the brow lifting, a reduction of the wrinkles and the skin sagging. And basically the results were measured, and they got a median or a variation between 1 point something millimeters to 3 millimeters of arching of the brow. And if you compare these two images, you see that the angle and positioning of the lateral eyebrow is much higher and gives a much useful aspect on this right side that is after treatment than when compared with the left side that is before treatment. So having all of these matters in mind, we have to choose our transducers. And basically, as we want to target all of the structures involved, we are using 3 transducers on this treatment. We will start with the 3 millimeter of 7 megahertz cartridge to treat frontalis muscle. Then we go to the 2 millimeter cartridge of 5.5 megahertz to treat the fascia, and for least the 1.5 7 megahertz cartridge to treat the dermis and further enhance this tightening effect. And basically the general technique is this one. We have to have always a 90-degree full contact with the skin with a transducer and applying some pressure, not too light to to not lose the proper contact between the two surfaces, but also not too hard, because if we press too much, the depths of the structures are changed, and we miss the point of choosing the cartridges. Um, on other hand, we have to apply a nice amount of gel. Usually I indicate a 1 millimeter thickness of the gel layer, because usually with 1 millimeter there is not too much gel to mess with your visualization field and contact of the handpiece with the skin. And in other hand, you have to have sufficient ultrasound gel to couple the electromagnetic stimuli to be delivered to the skin. Another thing that we have to have in mind is that we are applying on free skin areas, and we should not apply directly the technique on skin that is not bone based. So eventually on the upper eyelid, and that is what we are discussing today, but eventually also on the lower eyelid, that we have to push the skin downwards or upwards, as the situation needs, to be always on bone and on 90 degrees to the skin. Another thing, if we go through the Instagram nowadays, there is a trend to apply the microfocus ultrasound on an in motion way. And if I could be like an ultrasound police, I would get some fines of high speed, because when we apply the ultrasound in motion, we have to have a very slow movement to allow the penetration and the proper propagation of the ultrasound wave to our target. If we move the cartridge too fast, we are not delivering the amount of energy that we expect to, and the risk of burns are increased. So the technique for this area, eventually for all applications, should be or line by line or a very slow motion on an in motion way, to have a proper penetration of the ultrasound. When I talk about a very slow motion, is basically you need to move a centimeter on at least 2 to 3 seconds of movement. So it's a pretty slow movement. And usually for the ultrafox eye, we advise 3 sessions on a 3 to 4 weeks interval way. So let's start with the protocol. And we start with the lift of the tail of the brow, and we'll start treating the muscular zone. We pick the 3 millimeter cartridge with 0.5 joules of energy and a pitch of 1.2. Here we have to have in mind that we need a minimum skin fold to perform this cartridge, meaning that if you want to treat with the 3 millimeter spot, you have to do a skin fold and measure that skin fold. If that skin fold has a minimum of 6 millimeters, you can treat with this transducer. Or in other hand, if you have an ultrasound imaging on your practice, you can also measure the depth of the structures and see what cartridge is more suitable to your patient. And basically here, and with a very low pressure with the transducer, we distribute 15 lines in about 20 millimeters, starting on the lower border of the eyebrow tail, meaning that is the lateral third of the brow. And here we have to advise the patient to tell us if the patient feels anything like an electric shock. And this is because of the zygomatic temporal nerve. And if the patient feel, we should stop and not keep firing on that zone that the patient complained about. I should bring to the floor that there are not reported yet any permanent nerve damage with microfocused ultrasound. So usually when we have a nerve damage is temporary with a fairly quick recovery of the nerve injury. So first step is covered, lateral third of the brow, 3 millimeter, 20 millimeters of area of application, 15 lines of the 3 millimeter cartridge. Going to the second step. Now we go to the eyelid support when we got the MF2 cartridge starting the treatment. With a 0.2 joules of energy and a pitch of 1.2, we treat just the eyelid, and we should push the eyelid upwards to treat on the bone, as I told you about. And we should place 30 lines on this area till the upper border of the eyebrows. Let me just get a little bit backwards, and basically there is a line that helps us to define the safe zone of this treatment. And basically, if we draw a line on mid-pupillary line, if we treat to the outer part of the face from this line, usually we get outwards the central nerve danger zone. On the third step, we get again on the lateral third of the brow, but this time with the MF2 with the same settings as before. And we should apply 25 lines on a way of 20 millimeters on this side. And as we are treating the same side as the first step, we have to have in mind again the zygomatic temporal nerve branch. On the fourth step, we are working on tilting upwards the angle of the middle third to the lateral third of the brow. And here with the MF2 and the same settings as before, basically on the transition between the middle third and the lateral third, we start to apply 20 lines on the first 20 millimeters just above the eyebrow, and another 20 lines of MF2 from this ending point till the hairline. Here we have to have in mind the lateral branches of the supraarbitrary nerve that sometimes go around here and go upwards as the deep branches. And this is the point where it is more common for the patients to tell us about some discomfort that starts on the forehead and goes backwards, because this is actually the way the nerve goes backwards to on the head. And we are ending with the 1.5 millimeter cartridge, and basically we will cover the same zones as before. First, the lateral brow, the tail of the brow, applying 25 lines on 20 millimeters of way of treatment with 0.2 joules of energy and a pitch of 1.0. There are some cases where we don't use the 3 millimeter because the skin is too thin, and here we can increase the 0.2 to 0.3, but getting the pitch to 1.2. And here we also have to have in mind the zygomatic temporal nerve branch, but with the 1.5 millimeter cartridge, usually there are no implications with nerve, as the nerve is deeper than these 1.5 millimeters. And the sixth step is to apply also the On the same way, the 1.5 millimeter cartridge on the transition between the middle third to the lateral third, the first 20 lines on the 20 millimeters just above the eyebrow border, and the other 20 from the ending point till the hairline. And basically, the protocol is this one. I just want to remind you some useful combinations and remind you the importance to combine the MF2 with the 1.5 millimeter cartridge. Please have in mind that MF2 is not a strictly microfocused thermal injury zone, but is somehow between the microfocused and the macrofocused. So when we heat up with the MF2, basically we are already having some coagulation effect, but somehow we are lowering the impedance of the tissues. And basically we are allowing that applying afterwards the 1.5 millimeter cartridge, we have an enhanced effect of this last one. So we have a synergistic approach when we combine these two. We also know that for dealing the muscular hypertony and somehow modulating the muscular activity, it's somehow interesting to combine the ultrafox eyes with botulinum toxin. From the former indications and the official indications, we should wait 4 weeks between a session of ULTRAFORMER and the application of the botulinum toxin. But from the newer evidence that we are growing and developing, we also see that the 2 weeks is already safe to perform the ULTRAFORMER after the toxin without any significant risk of diminishing the effect of the toxin. And in the other hand, we know that on the eyelid we have a pretty thin skin, and it's the laxity is significant, and usually for having a pretty nice effect, but on this hand with some days, 5 to 7 days of downtime, we can join on the same session to the ULTRAFORMER as a last step, fractional CO2 on the free part of the eyelid to further enhance the skin tightening and the improvement of the skin texture on this zone. Let's move on to the results that we got. And before we start the specific results of the UltraFox eye, I would love to share this with you this couple of images. I know that the clinical significance of this comparison is pretty low, but this basically is a patient just afterwards lower third UltraFormer treatment, and just at the end of the session, please note how firm we get the skin, and the skin plague that we can somehow prick is 3 to 4 times diminished just after the treatment and not waiting from the regenerative 3-month response. So yes, we can modulate our tissues with UltraFormer and microfocus ultrasound, and yes, we have sufficient clinical evidence of its safety and efficacy. Here I bring to you a case that was half treated. Basically, on the right side of the image, the patient has not been treated, and on the right side, we have finished the treatment with the protocol that we have just discussed. And please note that the skin has barely no erythema, and we get almost 3 millimeters of raising of the tail of the eyebrow. And if you check, basically, even the angle that is made from the inner part to the tail part is much wider than compared with the other side. And I would like to show you the evolution of this patient along the years. This was the initial situation. from here to here, we've performed a full phase CO2 fractional laser and 2 vials of calcium hydroxyapatite for biostimulation. And from this point to this point, we made the volume repositioning with the hyaluronic acid and the ultrafox eye. Please note the structure of the brow, the angle of the brow, and the amount of skin that is shown below the brow to the skin fold of the eyelid. That is significantly improved and augmented. So we have palpable and tangible clinical effects. Here another case. Please note the angle of the eyebrow, the amount of skin that we are showing here. Please note that we saw here like a double plie starting to show on the lateral aspect that is almost solved after a treatment cycle, and we have a more refreshed, relaxed, and let me say sexy look after a treatment course. And here on a man too, this pic, sorry, but is just after a non-ablative erbium YAG, and we don't have before pictures than this. And the combination of the erbium YAG with the microfocus ultrasound, not only on the upper eyelid, but on the lower eyelid, gives us a pretty fresher look on the eyelids, even on a man. Obviously that on a man, we don't insist on the last steps of each cartridge. So basically we don't try to elevate and angle the brow, but we can go a little bit more inwards, to raise the brow evenly when there is a brow ptosis on the man, because we want to lift the brow and leave the brow horizontal and not angled. So for finishing, first of all, we all can state that ULTRAFORMER is the cutting-edge solution for treating upper third structure sagging, and the deep knowledge of anatomy and the aging is the key for me to a proper diagnosis and to a proper treatment plan. With this kind of protocol and technology, we can achieve tangible and reproducible results while combining safety and efficacy. And we are seeing low to no downtime procedures that fits the nowadays agenda needs of the business people that we see on our 21st century. And for enhanced results, we should explore potential synergies, as we have discussed, not only the combination between cartridges, but also the association with mainly botulinum toxin and lasers to get these refined results. And let me welcome to the future today, because with this kind of tools, we can provide to our patients a future today. So for finishing, I would like to thank your attention on this file, on Portuguese, obrigado, and starting with, as we start with provocation, we end with another one. If you are getting old, should you consider a facelift eventually? But first, we have to consider our ULTRAFORMER. Thank you very much, and I will be glad to answer your questions.
Thank you for sharing your insight on ULTRAFORMER III treatment. Now we move on to the Q&A sessions. Please feel free to leave your clinical questions on the chat box. Dr. Pedro will answer those questions shortly.
Okay, I will ask one by one, and I'll start to ask Yael, asking what's the reason to perform the treatments every 3 to 4 weeks interval. So if we are somehow coagulating proteins and coagulating collagen, we are inducing inflammatory reaction. And we know that the process to achieve the healing, or the first phase of healing of the collagen, we need 3 weeks to have that process, that biological process completed. So the minimum of interval is 3 weeks. Sometimes for easy or forget more the task of the scheduling easier, we schedule every 4 weeks to be a session every month. But if you asked me what, for me to give you an interval of time to EDL to perform another session, usually is 3 to 6 weeks. 3 minimum, as I already discussed, and 6 because after the 6th week we almost have no inflammatory or no subclinical inflammatory effect from the last session. And if we use this subclinical inflammation that's still on the tissue, we can somehow enhance the results of a further session. So for me, the interval should be 3 to 6 weeks, but the best is to be 3 to 4 weeks of interval between sessions. Line by line application. Basically, there are 2 ways of applying MFU. The first one is the classical one, that is this line by line. That is, you apply your cartridge on the skin and you let all the line to be delivered without moving the treatment head. The in motion one as a continuous motion movement while delivering the treatment lines. Answering the next question from Bozikov. Yes, I do therapy on and over the brows because we have a continuum of the tissue. So we have to treat all of the tissue to have the proper effect. And I take advantage of this line also to answer the next question, and saying that the microfocus ultrasound cannot affect the eyebrow heads, and the transducer can be applied directly on the eyebrows. Asking Osam, how many cases? I work with ULTRAFORMER almost 3 years on, and we have nowadays more than 400 to 500 cases of completed treatment cycles. We also on more young patients, we like to combine with botulinum toxin and just perform a single session of ultrafox eyes. And for me, these young patients with just a session and in combination with botulinum toxin and starting with the botulinum toxin are the patients that have a greater and nicer effect. But as I showed you on the presentation, I showed you a 70-year patient with severe skin elastosis and severe skin sagging with nice response to the therapy too. We have like less than 10% non-responders to the therapy, but this number, I think that is pretty is a pretty nice number because we all know that we have non-responders to all of the therapies that we perform, and on this case we have to seek combination with several other techniques to achieve the result that we want and the patient needs. Answering Paula de la Peña, if this is effective to the lower wrinkles on under the eyes for the very thin skin, yes, it is. But we have to have in mind that if we are talking about a very thin skin with severe skin ptosis, the indication is for a lower blepharoplasty. the skin thinning itself, it's not a limitation, but we have to have an integrated diagnostic activity to indicate the proper treatment to our patient. But yes, it can be used to treat the lower eyelid tiny wrinkles. Please have in mind to get the skin downwards to treat always on the bone, and when possible, to combine the MF2 with the 1.5 cartridge. Answering Dr. Bora, on the second and third session, we perform basically the same as the first session. So basically, is meeting the needs that we see, but usually the same lines and the same energy as on the first session, as I showed you before. If I recommend local anesthesia for sensitive patients, eventually, yes, we can use topical anesthetic. I don't think that nerve blocks are needed to perform these treatments, and considering the cartridges and the energy used. So on more sensitive, I would recommend a topical anesthetic, or eventually to use some cold therapy as a Zimmer device, or cold packs to cool down the skin, that somehow increases the comfort. Can we combine MFU with Botox, and Botox need to do 2 to 4 weeks before MFU, so MFU won't reduce the efficacy of the Botox? Yes, actually, if we wait at least 2 weeks, on our experience, we are not seeing a reduction of the effect of the Botox. The statement of the 4 weeks that we had before was based on expert consensus rather than solid clinical evidence that we are trying to gather right now and to publish as soon as we can. If there is eyebrow or eyelid ptosis caused by botulinum toxin, could we use this protocol? Basically, yes, we can, but we are not treating the cause. We can help somehow. We can start as soon as we can to try to somehow thermally diminish the effect of the toxin. And if you see at the week, you can also start the treatment right away. But please have in mind that after the second week, probably your ability to diminish the activity of the botulinum toxin thermally is starting to reduce. Can we do CO2 laser and MFU on the same day session? Which one is first? Yes, we can. Basically, it's thinking like a sandwich. You start with the bottom part of the bread and start putting your things till the upper part of the bread, meaning that you start with the deeper treatments and you end with the superficial ones, meaning that on this case, on the eyelid, you start with the MFU, the MF2 cartridge, and afterwards you do the CO2 laser just on top of it. Is there evidence of its combination with NDAG? Evidence, properly said, no, but basically, in talking about NDAG, we have plenty of NDAGs. We have picosecond NDAG, Cartridge NDAG, microsecond NDAG, long post NDAG. So we can, if we have the need to use any of these tools to address vascular issues or pigment issues, yes, we can combine on the same fashion as I discussed lightly with the CO2, is meaning that you should treat from deep components to the superficial ones. Can you explain what do you mean about distribution lines? Basically, I gave you some landmarks and saying that you have on, for instance, on the lateral eyebrow, on the first 20 millimeters, uh, starting from the upper part of the upper border of eyebrow upwards, you should apply somehow the lines and distribute to 25 lines on this area, on this 20 millimeter area, starting on the upper part of the eyebrow. And how much sessions we need, it depends on the patient needs, but usually for younger patients and in combination with botulinum toxin, just one session is enough. But even in younger patients, when we already have a significant proptosis, we have to perform the 3 sessions. I've already answered this question. The eyebrow hairs are not destroyed by MFU, so we can work directly over the eyebrow, and is also safe to work over tattooed eyebrows without any kind of concern or care on these situations. Do you control application through button on the end piece? Does each application translate to a line? I'm not sure I can understand the last part of the question. Usually I work with the end trigger always pressed along all the treatment area. And for instance, if I applied, for me, the most significant example is the upper eyelid, where I recommend to apply 30 lines. Usually we don't have space to apply the 30 lines straightforward. So basically I applied 2 sets of 15 lines, and that's it. I apply the first 15, I release the trigger, I go back to the starting point, press the trigger, and get the other 15 lines remaining. A line basically is all set of application of, if you trigger the button of the end piece once, it delivers you a line. Basically is that. And if you look for the literature about MFU, almost all of the papers are discussing the application by lines, meaning that on this certain area you should apply X number of lines, X number of shots. Okay, how long the result lasts after the third session? Basically, we schedule our patients to maintenance sessions every 6 months. And on that case, we only apply a single session and not a cycle of sessions. So usually is how we maintain. After a whole cycle of sessions, usually we see that the result lasts up to most 9 to 12 months. But as you don't want to lose the effect completely and then regain it, is more advisable to perform maintenance sessions every 6 months rather than wait for the effect to fade away completely and treat again. When can we see the max result of after the ultrafocus treatments? It's pretty variable. There are some patients that you actually can see immediately the result, and the result somehow remains stable. But there are some patients that you only can appreciate the stable effect 3 to 4 weeks after the session. Can we use the 3mm cartridge for eyebrow lift? Yes, but that's the best answer to your question. Basically, if we have a minimum of 6 millimeters of skin fold, or you can evaluate your patient with the ultrasound to see the depth of the muscular layer. If the muscular layer is somehow between 2.5 millimeters depth to 3, you can perform with 3mm cartridge. Please have in mind not only the zygomatic and temporal branches for seeking the symptoms while treating, as these branches are quite variable on the anatomical positioning, and please have significant amount of gel and low pressure while applying the 3.0 millimeter cartridge. How long after injecting fillers? How long after injecting fillers or threads can you perform MFU? It depends. Basically, on threads, there are papers there that recommend 6 weeks, but for me, and thinking about the PDO threads that are the more common ones, I would wait a minimum of 6 months, because we don't know what the intense thermal injury can produce to the thread and the molecules that are generating when we degrade this kind of plastic, because it's actually a plastic. And the filler issue, if the filler is deep, there is no significant problem, but usually on this area, the filler is more superficial. So whenever you have filler there, you always have some interaction with the filler. So it's better to perform the ULTRAFORMER first, and afterwards to fill the zone. Or for instance, if you have a patient that already has fillers there, you should advise the patient, if the effect of the filler, if the filler is still there, that might be some thermal degradation of the filler there. It's not a safety issue is with the fillers, but with the threads is, meaning that we should not degrade thermally the threads, because we don't know actually the consequences of that. But with the fillers is basically an issue of early degradation of the filler. How many shots should you say is max for droopy eyelid patients? Up to, and just discussing the upper eyelid, up the most 250 per eye, up the most, usually 175 or about that. Which is the better, line by line technique or slow movement technique? For me, I rather prefer the line by line, because we know that this kind of strategy would not mess with the propagation and the penetration of your ultrasound. So it's more precise to do line by line rather than on a slow movement. I only use the slow movement on 2 cases: when there is somehow some discomfort applying line by line, or on some very young patients for little touch-ups and so on, to distribute on a more diffuse pattern the energy. I use the slow movement technique. Basically, is how I choose my treatment technique, but 90% of the times is line by line application.
Dr. Pedro, we really appreciate your insight about Ultraformer 3 treatment and share your idea with us. Again, thank you for joining us today's webinar, and we are looking forward to seeing you soon.
Thank you. And if you need something else, please reach me by Instagram and email that you have on the bottom part of this slide. Thank you very much. Thank you, classes, for the invitation, and have a nice day, you all.